You taking this time out of your schedules to learn more about PDAB, review the challenges with this experimental approach to lowering patient out-of-pocket costs, and the impact of PDAB decision-making on the patient journey. Our panel today will not only explore policy, but I think we're very privileged because our panel will also share with you their experiences as patients. And in particular, we will be talking about the impact of PDAB on patients and how that could be catastrophic. Our panel today includes a very insightful faculty, and I'm very grateful for the opportunity to participate with each of you. And our faculty is drawn from the patient, physician, and academic communities. And there's overlap between those communities because of our panelists. And so we're very excited to learn more about your experiences, your insights, and understanding. They will be exploring various aspects of PDAB policy and how the Virginia bill can impact not only their access to current treatments for which patients currently have availability, but also to future therapies. And as many of those on this call already know, new therapies for patients with rare disease often mean hope, particularly given the enormous unmet medical need in the United States. Our panelists include Erica Fae, a Virginian metastatic breast cancer survivor, as well as an angel advocate with the Virginia-based Tiger Lily Foundation. Welcome, Erica. Dr. Harry Gewanter, the president of the Virginia Society of Rheumatology. And Dr. Gewanter is also just very involved in patient access issues and is someone that I have heard speak a number of times here in Virginia, and we're grateful for you as well. And then finally, Bill Sarraille, also a Virginia resident and professor of practice at the University of Maryland's Francis King Carey School of Law, a regulatory consultant and general counsel for the HIV and Hepatitis Policy Institute. And welcome, Bill.
Thank you.
And of course, I'm Michael Eaging, and I'm the executive director of the Rare Access Action Project, a Virginia-based nonprofit that focuses on ensuring rare disease patient access to healthcare and therapies. And while our membership is national, Virginia is our home. Today, the House of Delegates held a hearing in the Labor and Commerce Committee for House Bill 1724, the recently reintroduced PDAB bill. In that hearing, we once again heard from both the patron, Delegate Delaney, and supporters of the legislation praise for PDAB as a much-needed approach to rein in drug spending. While well-intentioned, proponents of the bill bring to the table little understanding of the complex life sciences marketplace, as well as the experience of patients, and particularly patients with rare diseases. This has been a challenge in many of the 11 states in which PDAB legislation has been passed. Since 2019, states with PDAB have been part of an experiment on price controls for an interstate marketplace. Rare disease patients are acutely aware of this, as few pharmacies stock many rare disease therapies, and many therapies are only offered from specialty hubs because of the small patient populations. And many rare patients seek care at centers of excellence for their rare disease that are in many instances out of state. And some of those centers of excellence provide not only direct care, but corollary services to those patients as well as their therapies. A PDAB upper payment limit, or UPL, would impact that care because plans would be constrained as to what they can pay for those products identified for UPLs, and particularly those products purchased out of state. And those upper payment limits set below acquisition costs could put those care centers at risk. In rare oncology, blood disorders, and other conditions that require physician-administered infusions, this could mean less access to care that is often part of the cost of the therapy. Since 2019, no PDAB has lowered patient costs, and these experimental programs have not fulfilled the promise of proponents to save either states, the system, or patients' money. So why does rare matter in this discussion? Well, only 5% of rare diseases have a treatment approved by the FDA. And for 1/3 of individuals with rare disease, it can take between 1 and 5 years to receive a proper diagnosis. In the United States, nearly 1 in 10 Americans suffer from a rare disease or condition. So a rare patient could be your neighbor, your friends, someone that you interact with in a community or a church. They are in your community here in Virginia. And of course, half of all diagnosed rare patients are children. And about 3 in 10 children with a rare disease won't live to see their 5th birthday. Patients face significant barriers to gain access to rare therapies across our healthcare system and in Virginia, including a patient journey filled with misdiagnosis and lack of treatment options. For those patients in which therapies essentially mean hope, they could also lose access to treatments for which they currently have coverage. At this time, I'll turn the time over to our panelists, who will share with you both a little bit more about themselves, as well as their insights into PDAB. But also, they will be able to also share with you how we as advocates have seen challenges in the implementation of PDAB in other states, as well as our concerns that we have also brought to the table in those states about the inability of PDAB to lower patient out-of-pocket costs. So first, I'd like to turn the time over to Erica, and then she will be followed by Dr. Gewanter. And our final panelist will be Bill Sarraille. After their remarks, we will discuss some of the topics that I outlined a moment ago, but we will also be open to questions from participants. Kelsey Haddow, our operations director, and I will be monitoring the chat, and we'll work them into the conversation with our panelists throughout the discussion. And so we hope to be able to conclude with that type of discussion and hopefully be able to answer some of your questions along the way. So Erica, I'll turn it over to you.
Hi, everyone. Thank you so much for the introduction. I'll just jump right in. I am a wife. I am a stepmom. I'm a social media specialist, and I love all things art related. I do photography and videography as well. And most importantly for this conversation, I am a Tiger Lily Angel advocate and a breast cancer survivor. I was diagnosed when I was 31 with stage 4 breast cancer. And treatment for me has looked like a mixture of combination of holistic treatments and conventional. So I've done chemo twice, I've done radiation, and I've had a mastectomy with reconstruction, and I'm still in treatment now. And PDABs for me, I look at them as creating a barrier that prevents patients like me access not only to life-saving medications, but to ones that provide a better quality of life. And that's something that every patient deserves. So right now I'm in treatment and I get a new immunotherapy infusion every 3 weeks. And what that looks like basically is I'll get the infusion and I need about a week of recovery time. And then after that, I have 2 weeks where I feel pretty much normal again. And that's when I can do everything that I'm passionate about, like being with family, doing our work, and those 2 weeks are like gold to me. So, this new medication provides me with somewhat of a normal life because of that, and the alternative of not having access to this new medication, for me, would be a severely diminished quality of life. I would be looking at doing chemotherapy again, so that's losing all of my hair and having all of the side effects that come with that, along with hormone blocking medications. So it's just very important for me to have access and, for it to be affordable, obviously, too. But these things are critical for my hope for the future and just having that quality of life. So yeah, that's my thoughts on PDABs. And with that being said, innovation and new drugs are critical, and PDABs harm the ability and opportunity for innovation to be available. So that to me is unacceptable. And we can't keep saying let's pass this bill and just see what it does. This is experimenting with patients' lives, and it's not with their consent. So it's unethical. And I think that, we need these new innovative therapies to be available, affordable, and, for the research to continue to happen so that patients like me can have access to medications that are prescribed to us. So with that being said, I will pass it back over to the next panelist.
All right. Thank you, Erica, and best wishes on the next part of your journey. I'm Harry Gewanter. I'm a semi-retired pediatric rheumatologist in Richmond, Virginia. I'm the current president of the Virginia Society of Rheumatology and past president of the Medical Society of Virginia. And I've been involved in a lot of policy issues regarding access to care for folks with treatments and, in some cases, no treatments. I'm of a sufficient age that I started practicing last century when we had literally nothing that could affect the course of people with arthritis. And now we have just fabulous drugs that we have to start coming up with a definition of a cure, not just disease control and maintenance. And that is just awesome. The problem is, of course, that there are high prices that go with this. And difficulty being a physician in a subspecialty is that many of the drugs that we use are either not on formulary or they're on top tiers of formulary. And in addition to all the other hoops and steps and everything else you have to go through, it may turn out that the drug you want and your patient wants, after much discussion, is not on formulary. And then you have to go through whole sorts of other problems. The difficulty that PDABs are going to bring to all of this is clearly evident in Colorado. They have decided that 3 drugs that are essential treatments for people with arthritis and psoriatic arthritis are unaffordable, as they say, which means that they are going to set a price that they consider to be affordable. They haven't figured out what that is yet, and they haven't figured out what that is. And as Mike said, that this is a grand experiment. So what's going to happen then is they will set a price, and if a pharmacy or pharmacy benefit manager or some other organization that purchases the drugs from the manufacturers to give to patients may or may not be able to afford to lose money by purchasing that drug at the price that the PDAB has set. The other complication of that is that one of the drugs is infusible, and they have not included any concept of how you can infuse a drug and remain whole financially to give that drug. So again, this may result in drugs, being affordable per the PDAB, but unavailable because they can't make it on the formulary. And there are a number of other predictable consequences that are downstream effects from these kinds of decisions that we can go through in a bit, but I'll pass it over to Bill to continue this, and we can, because I know a lot of people are going to have questions that they want to bring up. So Bill, it's on to you.
Well, great. I'm Bill Sarraille. I spent roughly 30 years as a healthcare regulatory lawyer, and I'm retired from the practice of law now, at least in the context of a law firm. I teach at the University of Maryland as a professor of practice and try to help with a number of different patient groups on a volunteer basis. And that work includes helping them sort of evaluate the legal and the policy issues that are raised by PDABs. Everything I will say today is my personal view, not to be ascribed to any of the organizations that I work with. I won't belabor introductory remarks, but really PDABs are incredibly well-intentioned, and the folks that support them obviously are trying to do good by a series of stakeholders, the patients, the states as payers, taxpayers, and everyone else along the way. But sadly, in the complicated space of healthcare, often the best of intentions lead us to, unfortunately, bad results because of the unintended consequences of policy that really hasn't been thought out. And PDABs are really at risk of living again that sad reaction, that sad outcome. And, one of the things that I'm most concerned about in the legislation that I've reviewed, including the proposal here in Virginia, is that there really isn't a guarantee that the prices that are going to be set by PDABs are actually going to benefit in any direct way the patients that are affected. That's a pretty singular and pretty fundamental concern. Beyond that, there is the risk that others have already alluded to that there could be a perverse outcome here where the reimbursement reality that's created for a group of stakeholders, the insurance companies, the pharmacy benefit managers, the providers, is such that a bunch of different stakeholders all have a financial incentive to move patients from products that are working for them, keeping them healthy, addressing the very substantial and important healthcare conditions that they have, and actually switching them, forcing them to use other products that may not be as good a fit for them. So those are pretty fundamental concerns. The Virginia bill, other legislation that has passed really don't address those two fundamental concerns. And that's a source of real concern for me.
Sorry, I was starting to talk and had my mute on, and I apologize. Thank you, Bill. Thank you, Harry. And thank you, Erica. I think those are really good starting points for our conversation today. Look, we've seen PDAB since 2019. Beginning in 2019, the first PDAB was passed in Maryland. And we've seen them unfold across the United States in the 10 or so states that have passed PDAB legislation. And, one of the fundamental premises, and Bill, you just kind of really focused in on it, is that there has been a lot of kind of a rosy outlook with PDAB, that it is going to lower prescription drug prices. Patients aren't going to pay as much for their drugs. We're going to take on big pharma. And at the same time, you have, for example, rare patients and other patient organizations, professional organizations saying, well, hold on a second, that's not necessarily how it works. And I think, as we talk to proponents of PDAB and some of our wonderful Virginia delegates and senators we've had many conversations with, why is it that, it's kind of a really neat promise that we can lower the costs and patients are going to save a ton, but why does it not translate so well in terms of policy? And I'll start with you, Bill, and then we'll go to Harry and Erica.
Well, the first problem is with the Virginia bill and with these state bills generally, is that there's nothing that guarantees patients access to the drugs that are targeted by a PDAB. And the premise, of course, of the legislation is always that patients will continue to have access to the drug just at a lower price for all stakeholders. But that premise, as you're indicating, is untested. And in fact, in many other circumstances where, we've seen attempts in good faith and well-intentioned by various policymakers to try and affect the price of various healthcare services, what happens is that if a particular healthcare item or service, a particular drug in this case, is targeted, and the ecosystem as a whole isn't changed, a bunch of different stakeholders that have power, the insurance companies, pharmacy benefit managers, providers who benefit from maximizing the spread from their acquisition price to the reimbursement value of the product that they use, they all still have an incentive that actually now carries them in a different direction, carries them towards a mechanism that says, all right, well, we don't like that price. We don't like the economic consequences of the imposition of that price. So we're now going to force that patient to take a different drug. And they have the power to do that through various mechanisms, utilization controls, formulary structure, a variety of different mechanisms. And that leaves the patient vulnerable to not getting any benefit from the lower price, and in fact, still being confronted by a price that maybe is unaffordable to that patient, but for a drug that isn't their drug of choice and may not even have the same clinical profile as the drug that was serving them so well previously. There's nothing in the Virginia bill or any of the other pieces of legislation to date that actually restricts the ability of plans, PBMs, and providers to switch patients. If we can't actually guarantee patients to ongoing access to the very drugs that we're targeting through this exercise, we're failing the patient at the very beginning.
Oh, thank you, Bill. Harry, I know you have some thoughts on this as well.
Right. Yeah, it's like how many hours? But I think the biggest issue and the question that gets missed is, this drug is unaffordable for who? And when you look at the model PDAB legislation, which is Virginia's is one, it has no discussion really about the patient. It talks about unaffordability for the state. It talks about unaffordability for health plans. And they talk about patients' costs, but all the cost and price are different. And they're only looking at doing something about the list price. And Kelsey, if you could bring up the graphic I sent you. This is a graphic from Adam Fine, and it goes through how the money and the drugs are distributed throughout the system. And what you can see is there is the manufacturer at the top who makes the medicine and then sends it out through a whole bunch of different, to PBMs, through wholesalers, to pharmacies, and money flows back and forth. PBMs are only going to focus on what the manufacturer charges. But as you can see here, the manufacturer has nothing to do with what the patient pays. What the patient pays is determined by the pharmacy benefit managers, the wholesaler, and the pharmacy price. And so PDABs not only, may not reduce the cost for the patient, they cannot reduce the cost for the patient because they are not addressing, as Bill said, the entire ecosystem. And as a result, they're doomed to failure. And one of the best analogies I recently heard, and I, will give credit to Jessica Frasco, who works for Heart Health Strategies in the Coalition of State Rheumatology Organizations, is if you tell a dairy farmer that he can only charge X amount for his milk, or you tell a chicken farmer that you only charge Y amount for their eggs, that has nothing to do with what you pay at the supermarket. And that analogy is perfect for PDABs. You can change the price that you're buying it at, but you're not going to change the price that the patient pays. And unless that is included, it can't work. And it sounds great, but to paraphrase and add, it's less filling.
And Harry, I hear this a lot when I speak with pharmacists, particularly local pharmacists about kind of what you put out here and outlined on your slide, but that system of payment charges, chargebacks, et cetera. And actually at the local pharmacy level, until it's the final payment, they don't necessarily know what's coming in and out until they get to the final resolution. So as we had mentioned, and Bill and Harry, you both mentioned, if the pharmacist is going to receive less than they paid for that medicine, then you have a real challenge there in terms of encouraging pharmacies, specialty pharmacies, doctors, clinics, et cetera, from actually both stocking and administering the medication, particularly since most medicines in Virginia are sourced from out of state.
Yeah. And the other issue that you can see on the slide is a thing called, you can see a little box called GPOs, and that's Group Purchasing Organization. And a lot of docs and PBMs and other folks use these organizations where you have a number of practices, for example, that will negotiate together to get a volume discount for the medicine from the manufacturer or the wholesaler. Well, if the price that the UPL sets is below what you can get from the GPL, you can't afford to do it. And if they want you to then switch to a medicine which is technically the same, but we know with rare patients and patients with immune diseases that I take care of, being the same ain't exactly the same. Every patient and every treatment is a chemical experiment. And once you get it right, you really don't want to change if you don't have to. And yet, if you look at it at a global sense, yeah, they're all in the same mode of action, but they may not be the same for that patient.
Well, thank you. Erica, do you have any thoughts before we're going to actually move on to some questions that are submitted by the audience as well in a moment?
Okay, yeah. For me, it's simple. I mean, patients should be able to take the medication that's prescribed to them by their doctor. That's the person in charge, and I feel like anytime a patient is having to make decisions about their treatment based off of finances or policy, then we've failed the patient. So that's my thoughts are really simple on this one and straightforward. And I think for me specifically, there is no alternative to the medication that I take now because it is so new, and there's not a lot of options for people that are with stage 4 cancer, and I'm sure with other rare diseases as well. So yeah, very simple.
We have a question from one of our participants in the audience is asking what the impact of PDAB price controls might be on clinical trials. And I thought that it was an interesting question because, when we saw the Inflation Reduction Act passed, not only RAAP, but other organizations modeled potential patient impact in rare diseases and warned that we could see closure of programs. And in fact, in the weeks and months after that, through the implementation of the IRA, we actually have seen rare disease development and clinical programs actually fold up. So I'd like to turn this discussion over to the panelists a little bit. Is what result do we think might have with these additional layer of price controls at the state level on not only availability to patients, and we've talked about now patients that have access, but what about the patients who may be waiting in the wings with hope of access to something in the future?
Well, I'm one of them. So my rare disease does not have a treatment. There are a number of companies that are working on development programs, and I've been waiting for my entire life for a treatment for myself, my children, my siblings. Unfortunately, lost a sibling to the disease in that wait. Look, there's not a debate about whether price controls or negotiation that some at least would identify as price controls is going to have an effect on the level of innovation, the commitment to innovation. The Congressional Budget Office, in looking at negotiated pricing under the Medicare program, conceded that it in fact would result in a number of products not being brought to market. It had a very different lower number than some other analysts had with respect to what the number of affected products would be, but there wasn't any doubt that it was going to have some effect. And that was without considering the idea that state PDABs would basically take those price controls or negotiated prices, as you might characterize or mischaracterize the federal policy, and sort of drag that same consequence into a larger set of patients, having that much more effect on pharmaceutical companies. The most unaffordable thing in the world is a treatment that never gets developed. And, I certainly am concerned that we are seeing at least the beginning of an effect on innovation by virtue of the combination of different price control mechanisms that include the efforts of PDAB supporters. In my particular area, we had a phase 3 trial that fell just short of statistical significance on a measure. And rather shockingly, the sponsor decided, well, close is not close enough. And they decided to pull the program as a whole rather than initiate a new phase 3 trial, despite that very close outcome with respect to the one that they had already funded. They didn't say that that was because of the risk that they face in the new world of Medicare negotiated price and burgeoning PDAB legislation, but I have to wonder if that wasn't at least part of their calculus.
Thank you. Move on to another question, and this again is from one of our audience. The Partnership for Safe Medicines has concerns that any kind of price controls will contribute to gray market areas, where unscrupulous operators will shuttle UPL regulated medicines out of the state to other states where more money can be made. We've seen this in Europe. We've seen this, in other countries where it gets shuttled across borders depending on the price controls. We've already seen this for drug shortages in lidocaine, which is often purchased just to flip to other states. This would cause access issues for patients. Can you comment on this with regards to the Virginia legislation?
Welcome to capitalism.
Yes.
No, I mean, that's the reality of it. And, again, people are going to do what they can to get the care they need or to make money. And, clearly that's a situation that, again, it's a predictable consequence of all of this.
Yes, couldn't agree more. Rare disease patients, because they're so hard to diagnose and treat, are disproportionately treated by large academic medical centers that often operate in large networks over different states. So one risk is that patients that are even maintained on their pre-existing drug are treated at different care sites in different states within the same system that is not subject to the same price control mechanism. So this could impose on patients in Virginia the risk that a network that extends into West Virginia or the District of Columbia or Maryland might actually be transferred for care within the network at unfortunate cost to them, given perhaps the limitations of their rare disease. in order to offset the financial and economic incentives that would be created to do exactly that.
Thank you. Erica, anything that you wanted to add on that one? I know we got.
Yeah, I feel like everyone has said everything. Yeah.
So let's go to the next question, because I think this one, and Erica, I'd be interested in your thoughts on the next one as well. Is that, as we craft these bills, and particularly, for example, in Virginia, how come there aren't protections for patients? And in particular, here's the question. How come these bills don't have stipulations that patients can continue on their medication? It seems like not allowing the drug distributors to shortchange patients should be high on both the doctor and legislators' priority. Now, Bill and Harry, you both talked about some of the consequences through the drug distribution system. And so would like to really kind of relate that back to the patient is, why don't we see those types of protections, and could that type of protection even work?
Right. I feel like one of the first things that could really help in this area is having patients more involved in the PDAB itself. So if they're on the boards, then they can help make these decisions that help protect the patient. I think if you don't have their perspective added to the conversation, then you start to run in these kinds of issues where their needs are being ignored, maybe intentionally or unintentionally, but having them there and able to speak for themselves and what they need, I feel like that'll help turn this corner.
Yeah, and I would echo that. None of the PDAB bills require a patient or a prescriber to be on the board. They put them on advisory councils who can be easily ignored by the board. And so you have people who, as you've said, Mike, this is a big experiment. And theoretically, gosh, this sounds great. And so we're going to have a bunch of theorists on the board, but not people who know what's happening in reality. I think that is a significant problem. But I think the other point about this is it's not about patients. You listen to the name, it's affordability. It's about the money, it's not about the patient. And it says that up front.
Mm.
I think we heard that today in the committee hearing, where it was really, that was the focus. It was kind of came through, particularly as they opened it up then for patient comment, is that, we've been here before, we know what we're doing, and thanks. Bill, do you have any thoughts about this? Because we talked about the challenge of pulling through coverage, particularly when, for example, a product might not be affordable now in that state because the UPL is less than the acquisition cost. And so how would you be able to protect patient access, or could you?
Well, you could try to create a mandate that requires as a condition of the legislation that insurers and PBMs, state healthcare programs, continue to provide access once a UPL is established. None of the legislation that is passed so far requires that, and the Virginia bill does not propose that. The reality, sadly, is that even if that were a mandate, it's one of those things that, given the many levers that payers have, PBMs have, providers have in influencing the therapy that is made available to patients, it would likely be something that could be subverted, even if that mandate were in fact to be imposed by law. So that's a doubly harsh reality to confront here. One, the advocates for PDABs don't think to make it a mandate in the first instance, perhaps because at least some of them are so anti-pharmaceutical manufacturer that they're actually hoping to cripple these therapies in favor of other therapies. But even if we put that degree of cynicism to the side, if there were a mandate, it would be a very difficult mandate to enforce. This is part of the cruel reality of unintended consequences when you have an ecosystem as complicated as the one that we're talking about.
And I think the other part of, that we need to remind everybody is that the PDAB is an authority unto itself. It has no accountability to anybody beyond itself as well. Because they are.
I think Harry froze.
I think he did.
Other issue.
I was wondering if it was me for a moment. So
Yeah.
No, it's me. It's between 9 and 11 after the hour, and Comcast decides to cut out on me on a regular basis.
well, let's move along to the next question. And thank you for submitting that previous question to our audience. And as you can see, patient protection is really critical. And because of the way that PDAB actually interfaces with the healthcare system, it doesn't necessarily lend itself to providing patient protections. And so I think that is a pretty fair summation of our discussion that we've had. And I think it's important for people to remember that. So let's move on to the next one, because we did touch upon it earlier. And I find this one really, really important. Now, we know that rare disease patients often find that their prescriptions are fulfilled, not necessarily by their local or independent pharmacy, but by out-of-state specialty pharmacies because of the small nature of the patient population. There's usually one hub, one entry point, and it's sent directly from, in many instances, out of state. Whether it's to the hospital for an infusion or to the patient if they do it at home or take their treatment at home. So this is a question that is more broadly and particularly important to chronic care patients and other patients. And so I'd like to tee up the question, and then we can talk about it for a moment. How is PDAB going to impact independent pharmacies? Do you feel that PDABs actually funnel prescriptions into vertically integrated PBMs? Now, we may have to just talk a little bit about that for our audience, a little bit about a vertically integrated PBM. But, I think the thrust of the question is, will PDAB really sidestep local and community pharmacies and really make bigger purchasers and some of these larger PBM purchasers more important? So I'll turn it over to our panel and see what your thoughts are.
I would say probably yes. Unfortunately, the strains that independent pharmacies are operating under certainly are not limited to what is being created or could be created by PDAB. So I don't want to overstate the case specifically with regard to PDABs, but it's certainly true that to the extent that you create a mechanism by which there are incentives created to favor larger entities that are better able to address the potential difficulties that are created between the prices at which they acquire product and get reimbursed for that product. They have more in the way of financial reserves to deal with those sorts of carrying cost issues. And to the extent that you create a financial incentive to have more control over patients and to force their switching from one product to another, you are favoring the most powerful actors within the ecosystem to the disadvantage of the less powerful participants in the system. And so that's a long-winded way of saying that PBMs with their own captive specialty pharmacies and in some cases retail pharmacies are the ones who are probably the most likely to benefit from some of the opportunities for manipulation that come from the imposition of a price control like this.
I think if you look at the bill, it specifically, again, references the state and health insurers and other payers. It says nothing about patients, being the primary consideration, and they don't consider pharmacies at all within the legislation. So, on the one hand, one could be, Pollyannish and say, oh, well, this is all theoretical exercise and let's see what happens. But, as Bill said, we know how this system works and we know who's pulling the levers. And, the vertical integration of having 3 companies that have insurance plans, PBMs, pharmacies, specialty pharmacies, group purchasing organizations, and a whole variety of other subsidiaries and agents working for them are going to do much better in making sure that they don't lose anything as compared to your independent pharmacy. I mean, again, I think that's just a given. Unfortunately, to be really cynical, what we're seeing are single payer, for-profit, non-transparent systems being created in the United States, where they own physicians, surgical centers, all sorts of things, top to bottom. And a UPL like this to them, is just another opportunity to do better.
Well, thank you. That was, a very interesting discussion. I think about rare diseases, and the rare disease patients who travel to centers of excellence, and some of, the challenge with placing those centers of excellence at risk, for, acquiring a medicine that they may have to acquire at a higher price than a UPL. But then also the patient, when their insurance only pays up to the UPL, who pays the risk? Who pays the remainder? And we've seen even in today's marketplace, some centers of excellence are requiring brown bagging, or the patient to actually have the drug sent to them paid, so that they can then infuse it at the center. So again, it feels to me like shifting more responsibility to the patient in order to impose a price control, and then leaving the patient either at risk for a higher cost at the other end above the UPL if they're someplace that can't get it at that price, or that they may be required to brown bag and figure out the payment through their plan before they even go. And again, Erica, as you know, from navigating, regular infusions and, treatments, that's just an added burden onto a patient that's already trying to manage something as intense as chemotherapy or a rare disease therapy on a regular intensive basis, to now have to juggle access to their own medicine.
Yeah, it's the last thing that you want to deal with. Like you said, it's hard enough just navigating such a difficult health situation. The last thing you want to worry about is, how am I going to afford this? Am I going to be able to get this? And all these other questions, they should not be in the picture.
Agreed. Bill or Harry, any thoughts about that and the potential risk or exposure to patients here? Since
Well, I think, the whole issue of, again, this is the tangent about brown bagging and white bagging for the audience. Brown bagging is when a specialty pharmacy sends a medication to the patient and the patient brings it in to be administered. White bagging is a situation where the specialty pharmacy sends the medication directly to the clinician to be given. Both of these are less expensive for the supplier, more expensive and bothersome for the patient, and potentially risky for the clinician who is going to infuse the medicines, because you have no knowledge of the chain of custody involved. Plus, you can only administer this drug to this patient. And if there is any issue with the patient, they gained weight, they lost weight, whatever, they're sick and they can't get it that day, you can't use that medicine for anybody else. And so that is an inherent problem with this. I think part of the question of, with the PDABs, I'll give a positive spin on them, is that it's going to take so damn long for them to come up with the UPL for many medications that we may be saved by their inability to work efficiently on any of these things. And that's the ray of hope I've got within all of this.
Great. Well, let's move on to the next question, because it does kind of build on this a little bit. And I don't feel like I'm going to be qualified for an answer. So if there is some information that you all can share, that would be terrific. Have you seen any involvement with the wholesalers who actually are the direct distributors of medications to the pharmacy, and may this be impacted by this policy? Now, we've talked a little bit about this, but we really haven't dug back a little bit deeper to talk about the wholesalers and where they might fit into this. We've talked a lot about PBMs. We've talked a lot about the plans and independent pharmacy. But have any of our panelists worked with some of the wholesalers and some of the big, distributors, and share any information that you might have?
Harry, do you want to start?
Sure. Yeah. I think, again, just like the PBMs, they are not included within the PDAB's purview. And so they're going to have just as many opportunities to do whatever they want, at least is my interpretation of the bills. Unless, as Bill so eloquently put it, unless you're including the entire ecosystem, you're not going to, change it, and it creates opportunities for gaming. And I don't see any difference for the wholesalers than PBMs. And, Bill, maybe you've got a different thought about it.
Yeah, I don't have any particular insight into what wholesalers are actually thinking related to PDABs, but my guess would be that at least two strategies that they would be considering is turning back to manufacturers and saying, hey, I need a chargeback adjustment in order to deal with this situation. Which is, sort of a tried and true approach for wholesalers in trying to shift risk back to manufacturers. I would think that it's also important to note, though, that wholesalers do have a significant degree of ability to influence the mix of drugs that their customers purchase. And that could mean that they are among those stakeholders when confronted with a class of drug for which one option has been targeted for an upper payment limit and the others haven't, in which they become one of the many stakeholders who are trying to facilitate switches of patients from an existing product that they're using to benefit themselves, they're experiencing good outcomes from, to other options, which may or may not have as good an impact on those patients. So again, if you create incentives in a complicated ecosystem to move patients from products that are working for them, you will in fact move patients from those products to other products.
Thank you. Thanks to all of you for jumping in on that question. That is a challenging question to really think through. And I think my follow-up question is going to be just as challenging. And I did want to talk a little bit about this because in rare disease, as well as in other specialty diseases, you often have a significant proportion of the population accessing their therapies through Medicaid, through 340B programs, through basically programs that are intended to provide access to those in need. And, the PDAB, the potential to disrupt those programs is significant. And so I wanted to ask, given the potential impact with some of these programs, what do you see as the potential challenges that patients could face in Medicaid or 340B program? And how do we mitigate that or express that to policymakers who believe that PDAB is going to suddenly help their state budget or help lower costs that are outlaid to Medicaid or 340B patients?
Well, I'll start. Perhaps others will add in here. Let's start with 340B. We already have, at least I think we already have, a clear indication of how 340B providers who have a terrific incentive to use highly reimbursed products will react to a situation in which particular products are targeted by a PDAB and lower significantly the reimbursements that are associated with those products. How do we know that? We know that based on what 340B covered entities are saying is going to be their response to Medicare negotiated prices. And what they say upfront without any hesitation is, look, if I as a 340B provider have a choice between maintaining a patient on what is now a low reimbursed product versus switching that patient to an alternative highly reimbursed product, it is a no-brainer for what I will do. I will move that patient. I will switch that patient. On the Medicaid side, Medicaid is a terrible payer generally. And one of the things that allows a number of different providers in the ecosystem to make commitments to Medicaid patients, notwithstanding the overall terrible reimbursement rates that apply in Medicaid programs, is that there is some financial opportunity in connection with drug therapies for Medicaid patients. This is true, for instance, for cancer patients. If you now have PDABs effectively undercutting what is one of the relative bright spots in the Medicaid reimbursement landscape, you run a real risk of undermining even those providers now willing to provide services to Medicaid patients. That could make a bad access problem in Medicaid worse.
Yeah, I agree. And I think, the vision of, people who run Medicaid, they may be seeing this as a real savings for them. And given, the current discussions in Washington about cuts that may be coming to Medicaid, and Medicaid being the number one expense for a state, they may look at this as a way of saving some money. Unfortunately, again, it will result in changes of therapy and more difficulties for patients. And Bill's assessment about the 340B is spot on. They're just going to move on. I mean, I can tell you a story. A friend of mine is on a very expensive drug for a genetic condition he has, and it's been getting it infused. And the hospital system that he was getting infused at after 10 years said, well, we have to switch you to the other hospital system in town because we can't afford to get this medicine anymore. And without saying it making a profit, the other hospital system had 340B access. And so that way they could afford to do that. I think, that it's, simple accounting.
It is interesting because as I work with rare disease patients, and like I said, our rare disease patients, a significant proportion of them across many indications utilize and rely on 340B programs and rely on Medicaid for access to their therapies. And so we really are talking about the most vulnerable of the vulnerable in rare diseases. And, the challenges that are already in place in Medicaid to get access to a rare disease therapy are enormous, sometimes resulting in hours of physician and staff time just to get the backup information, fill out the prior authorization information, and doing this only to now potentially have a therapy out of reach in the program. It's actually fairly frightening. And, with PDAB and the way that it will potentially undermine both the Medicaid program as well as the rebates and other things that the Medicaid rebate relies on to make these products affordable to patients is enormous, and it's not talked about as much. And I do think that states thinking that they are going to suddenly save money from a PDAB and then watch maybe the hospitalizations, the additional tests, the additional physician billing and staff work to now manage a patient that's not on the right therapy when they were on the right therapy is enormous, the risk. And so, I think this has been a really important discussion and one that's not talked about enough as we discuss PDABs is those populations that rely on these government programs and their inability to seek both therapy and care in other places. So I think this is a really important discussion and one that in Virginia that our legislators need to understand more before they sign on to an experimental program like PDAB. So I'm going to turn it over to each of you.
I was just going to add in one thought for you, Michael, that was made during the hearing today was that there's a significant amount of whataboutism with this was, the sponsor talking about, pharmacy folks spending more money on marketing than on research. And, whether, you like that or not, one can also just say, what is the point of creating a product for which, as there was a recent report, whatever your charges are, you get less than half the money back. And that part is not discussed in a UPL or about a PDAB, that, where does all the money go between the list price and the net price? And, a very easy way to make PDABs better is that the UPL is the patient's UPL, not the list price, not the purchase price UPL.
I think that's an important point that you brought out because that is a fallback point on this discussion and many other discussions in healthcare. And when particularly coming from my rare disease background, my father died of a rare cancer, and of course the therapies that would have saved him were years away. And yet, as you look at some of these therapies and the ability to treat maybe 500, 1,000, 1,500, or 2,500, these are not mass market products. And, a lot of them come from, small companies. A lot of them come from companies that were founded by families and foundations and others, because there was not a significant return in those products to actually do some of the things, Harry, that you described that were used at the hearing today. And so it really is important for us to refocus on the impact on patients and the impact on not only access to the therapy that they have today, but then what does a PDAB do and the potential for a PDAB decision do to the product of tomorrow? And is this an experiment that we're willing to accept, that a patient could be separated or severed from a product that is potentially life-saving? Or are there things that we can pursue that will actually help patients and patient out-of-pockets? You know, in Virginia, for example, we've been working with a coalition of patient organizations on a capped out-of-pocket copay bill, basically to allow plans to offer options that allow them to cap the out-of-pockets rather than percentage copays, which is a significant step forward. A number of states have passed this type of legislation. Virginia was a trailblazer on copay accumulators, bipartisan. And yet we've seen data recently, because of the way the copay accumulator bills were structured, that there's not a lot of enforcement or oversight. And so plans have been able to kind of move around those. And again, the cost gets shifted to the patient. But we also have maximizer programs, and we have alternative funding programs, which again shift responsibility to patients who think they have coverage in their plan back on them to find coverage. And so these are things that we could work on, including risk pooling for high-risk patients, including rare disease patients, that could help drive down their insurance costs. There's a number of things that we could do to lower the cost to patients. And, you know, and Virginia has been a leader here, and hopefully will continue to be a leader. And, you know, but PDAB's not the right prescription. I'll give each of you one minute to just final comment, and then we do need to close. And so again, thank you to all of you. I'll turn it over to each of you for just one closing comment. Erica, we'll start with you, and then we'll move to Harry and then Bill.
So first of all, I just want to say thank you so much for involving me in this panel. It's been an honor to speak with you guys, and I'll just keep it brief. I just feel like every patient deserves access to the best drug that's prescribed to them, and that it's affordable and it's effective for them. So if PDABs get in the way of that, then we need to rethink this.
Thank you, Eric.
And I'll echo, you know, Erica's comment. And it's really been a privilege to be part of the panel tonight. And you know, I just keep coming back to the question of affordability for who. And it needs to be affordability for the patient, not for the companies that are in between the physician and the patients receiving the right therapies. And again, thank you for asking me to be a part of this.
Thank you, Harry. Bill?
And for me, Michael, thank you for you and your colleagues, what you're doing every day. Appreciate the opportunity to be on this panel, but appreciate you and your work.
Well, thank you. And thank you to all of you. And thank you to those who attended tonight. As always, if you have any questions or follow-up questions that you would like to submit to either the panel, I apologize for the siren outside my room. But if you have any questions, additional information, please feel free to reach out to us at RAAP. We would be happy to help you find the information. And again, we work with our panelists. If there's any follow-up questions, we would be more than happy to get them those questions so that you can get the answers to your questions or concerns. So again, thank you to all of you. We appreciate your time, and we look forward to working with many of you for solutions to patient access issues. There are a number of things that we can work on together, and we look forward to those conversations. Thank you.
And Mike, just a reminder, we are going to be doing an advocacy day down on Capitol Hill in Richmond on the 28th, and we will get more information out to everyone regarding that.
Terrific. Thank you, everyone.